Good afternoon, everybody. We're going to let some people to join, so give a couple of minutes, and we will be starting this IAS-USA dialogue on emerging infections and health threats. Welcome to all of you who are logging in at the moment, and just we'll give it a couple of minutes, and then we'll go ahead and get started. Well, hello. My name is Carlos Del Rio, and on behalf of the IAS-USA, I want to welcome you today to this dialogue on our series on emerging infections and health threats. I am a professor of medicine at Emory in infectious disease at Emory University in Atlanta, Georgia. And joining me as discussants in today's dialogue are Dr. Yvonne or Bonnie Maldonado from Stanford University and Dr. Peter Ching Hong from University of California, San Francisco, which have been part of this series now for several, I guess, months or even years. So welcome, Bonnie. Welcome, Peter. Lots to talk about. So why don't we go ahead and get started? As we were about to log in, we were listening to the ACIP meeting, and we were seeing also the news that the ACIP has decided to change the immunization schedule for pediatric hepatitis B vaccination. So maybe, Bonnie, you can start about why is this significant and why is this concerning?
Yeah, thank you, Carlos, and it's great to see you and Peter and the rest of the team here, and thanks to all of our viewers. The Secretary of HHS disbanded the traditional ACIP membership,
Of which you were part of, by the way.
of which I was part of.
So you were disbanded.
Yeah, we were all terminated in June of this year, and within 48 hours, new membership was put together. And over the last few months, they've had 3 meetings, one in June, one in September, and another one just going on to yesterday and today. They currently have 11 members, although that membership keeps shifting as well. And what was discussed.
So Bonnie, before you go there,
Yeah.
I've been a member of the advisory committee, not of the ACIP, but other government advisory committees as a special government employee. There's a clearance process that you have to go through to be a special government employee. It's not immediate. It's not rapid. So there's a lot of ethics clearance. There's a lot of training you have to take. I suspect the current ACIP members are probably not went through that clearance as SGAs.
So it's really hard to know. You're right. It took me 3 years from the time I was asked to put my nomination in until the time I was actually sworn in as a special government employee. 3 years. And most of the members took somewhere between 1 and 2 to 3 years. I think the pandemic slowed us down a bit, but lots of training. And I don't think they got much training. I mean, they were sworn in 48 hours, and some of them have come in more recently. I think they have apparently gotten some additional training. They allude to it, but I don't think it was the same kind of training we've gotten because many of the processes at the ACIP and CDC have really been tossed aside. But I will say that the members are generally speaking, I wouldn't say all of them, but generally speaking, are not experts in vaccinology. They don't understand systems vaccinology. They don't understand immunology. They don't even understand basic concepts of clinical trials and study designs. They don't understand concepts like incidence and prevalence. And they really don't understand the history of the U.S. immunization schedule for children or adults. And there are a few people on there who know bits and pieces, but really, this is a group that they call themselves rookies. Now, you don't want rookies to be managing the Federal Advisory Committee to the singular public health agency of the U.S. that sets vaccine policy. So these are the people that are running these trials, and the comments that are coming out of this meeting are stupendously inaccurate and incredibly misinformed. And I hate to say it, but really ignorant. They just don't understand.
So tell us why is it important to have a hepatitis B vaccination at childhood?
Yes. So hepatitis B, as we all know, is in endemic in the world. We have not we have not eliminated it, but we've tried with our different varieties of hepatitis B vaccine over the decades to really address high risk groups, right? So initially we started with high risk groups, people who are exposed to bloodborne pathogen, more likely to be exposed to bloodborne pathogens or through sexual or other contact. And that did put a dent in some disease. But what we were finding is that more and more we were not reaching all of the hepatitis B disease in the US. And we saw that there were thousands of cases of perinatal disease, that is from a pregnant infected woman to her child. So screening programs were set up. The problem with screening programs is not everybody in the US gets universal health care or prenatal care. So there were missed opportunities. And we weren't seeing the targeted screening approach and vaccination really put a big dent in hepatitis B. And so in 1991, a universal dose of hepatitis B followed by two additional doses at 2 to 4 months, and then and at 6 to 18 months of age were then recommended. Since 1991, so 34 years now, we have seen the number of perinatal childhood hepatitis B cases drop from about 16,000 to 20 in the last year that it was documented. This was from CIDRAP. So we almost eliminated childhood hepatitis B in the US. It's not completely gone because adults are still infected. And we know that of the 2.5 million or so people who are infected, about half or more don't know that they're infected because it's silent disease for many, many years. So we need to continue this to give that universal vaccination in order to protect babies, not only because their mothers might be infected, but because caregivers or others in their environment could pose a risk to them to be infected in young childhood. And we also know that the vaccine provides almost lifelong immunity, at least 30 years, we think. So that's really important. This is a stunning vaccine with almost no safety signals. There are fevers and fussiness that have been documented. But this group has really just voted today to take away the newborn dose and allow families to use a dose at 2 months of age with shared clinical decision making, which does not make it a universal recommendation. And I suspect that pediatricians and other providers will be confused, and we may see a drop off in the utilization of this vaccine.
But the other issue I think worth mentioning is acquiring hepatitis B in childhood, in infancy, you're more likely to have chronic disease. You're more likely to get chronic hepatitis B than if you get it as an
Yes.
adult, and therefore you're more likely to go on and develop
Right.
hepatocellular
And so
carcinoma.
yeah, absolutely. When you look at the complications of hepatitis, and these are studies done by Palmer Beasley and many other people in the 60s and 70s among high incidence populations outside the US, these are incredibly well documented studies. If a child under 5 years of age, and especially in the perinatal period, gets infected, and they are very highly likely to be infected with perinatal transmission, they have a 90% chance of developing chronic disease compared to an adult or a child over 5 and an adult has about a 5% chance of developing chronic disease. Now, that 90% of kids who will be infected, they have about a quarter, 1 in 4 will have risk for hepatocellular carcinoma. They also have risk for developing cirrhosis and other really serious life-threatening complications. So the risk to the infant is incredibly high for severe complications and death. And we obviously see that in the older population as well, but not to the high percentage that we see in the newborn.
So, Peter, what are you going to tell? I mean, after this meeting, when people come ask and say, "Should I vaccinate my kids?" What are we going to tell people?
I would say absolutely vaccinate the kids. I think I'm somewhat reassured by there was a study or public opinion survey from the Annenberg Policy Institute of University of Pennsylvania, and they asked patients, who are you going to trust, the CDC or medical bodies, i.e. physicians? And this dovetails with some earlier stuff by the Kaiser Family Foundation, and about twice as many people are going to listen to medical professional bodies and clinicians per se than say CDC right now. So the reason why I'm saying that is that we have a lot of power we can't sort of have this feeling of fatalism. So I still remain optimistic that at least with the individuals that I touch, of course, on a systemic level, it's very challenging. But the more we talk to our colleagues, the more we keep that message up with patients, we have a very powerful voice. So yes, I'm going to talk about the impact, not just on infection. I think people just think about, infections, the outcome, but of the downstream effects of liver cirrhosis, hepatocellular carcinoma, transplantation. I'm a transplant infectious disease doctor, and you know, in the early days, everyone talked about all these hepatitis patients that would come for liver transplant is very, very challenging. I have family members who acquired it perinatally in Asia, so I think that it does hit home hard, and I think apart from data, personally, I also talk to patients from a story perspective.
Yeah, I think you make a good point. We have to talk about personal stories, right? And I talk about my children, and I talk about my grandchildren, and why I elected to get them vaccinated. And I explain to them the reasons, as you say, is not only to prevent infection, but to prevent the long-term complications. So moving on, so hepatitis B, I think, we continue to say this is a safe vaccine, it's an effective vaccine. We want to give it. Don't miss the opportunity not to get it. The next
So,
vaccine,
Carlos, let me
obviously,
just mention one other issue that I think is really at the heart of all of these skeptics is we are actually victim. We keep saying we're victims of success, but this brought up over and over again today and the meeting at ACIP yesterday and today. There's no risk for getting hepatitis B. Look, there's no risk. Why should we get that? Why should our kids get vaccinated? Well, we're exactly at low risk because of vaccination. So it would be like saying, stop signs have worked. We don't have
well,
any more traffic accidents.
I'm going to
Let's
stop.
just,
Yeah, I'm going
yeah,
to stop using my seatbelt, right? I mean, there's
yeah,
no.
let's stop using,
Or you go
safety,
skiing,
right?
why wear a helmet?
Yeah,
Accidents are down, right?
exactly. So this is how ignorant these arguments are. They don't understand how epidemiology and population health work. But then when
Well,
you bring that up, they say, well, you're not thinking of the individual and the individual risk. Well, the risk is incredibly low for any real complication.
But
well, let's.
we made, yeah.
Yeah.
I mean, the one other thing I wanted to bring up before we move on to is that whole, again, idea of checking antibodies after you get vaccine. What another barrier. So all of these, we are shocked by them bringing up all these these hoops to jump through. But again, from a lot of people, what it's doing is just making it a minefield of all these things that people are going to get confused over, including clinicians. So that is going to be the effect of just lowering vaccination rates.
So let me just explain to you what this means. What they are saying is if you get a baby who gets their first dose of hepatitis B at say 2 months now instead of a year of newborn, they then are saying, and this just popped up yesterday as an aside. This is a vote that they took with less than 24 hours of discussion. Let's make sure families ask for serology documented that they got an antibody response to the first dose, which means that now they don't have to get the rest of the vaccine series. That is so anti-scientific. That is so unprecedented. So basically using serology for anything, and the actual expert who wrote the paper on serology was on the call and they discounted everything she said because serologic testing does not equate long-term immunity. As we all know, antibody titers drop over time. You might need more than one dose in order to get lifelong full immunity. So this idea that these random group of people can just say, oh, you know what, let's just tell people to get an antibody test. And if they're positive, then they don't need to get the next set of antibodies. They voted on that and they passed the vote today.
Yeah, it's truly amazing. Well, right before Thanksgiving, I'm going to move on to another issue, but right before Thanksgiving, we all saw how the CDC website on vaccines and autism changed, and there was a change that all of us were totally shocked about. So Bonnie, maybe start with you. What is the lack of evidence, and why this is so disturbing?
Well, this has been a very familiar trope from the secretary since his days working in industry, and these are not unfamiliar. The tropes that we've been hearing have been spouted over and over and over. We hear them in the pediatric world for sure. for many years. And generally, we were able to discount them by providing data and science and communication. But when you have the secretary of HHS at that high level, making these not only comments, but putting these on the CDC federal official website, people start to listen. And the data on autism has been documented in many hundreds of studies, but there are at least 40 studies involving millions of children, not just in the US, but around the world, looking at vaccinated versus unvaccinated children and documenting that there are no associations between autism and vaccination. Now, in particular, there are 2 or 3 studies that were done by a family, the Geyer father and son trio, not physicians, not medical experts, who actually were criticized for their papers because the data were not well studied. And they purport to show that autism does have an association with vaccination, but their papers have been roundly discredited by other experts in the field. And so those are the only papers that these groups have been pointing to, because every other study in the world has not demonstrated a link. Now, we do see autism, and there is probably multifactorial reasons for that, and we need to address it. But vaccines are not one of the issues on the table around what is causing autism.
Yeah, absolutely. And I think you said it right. So, Peter, we continue to see cases of measles. Measles going up. Measles vaccination rates are dropping. 2 things that are relevant, recent, is we have the Secretary of HHS and the President, and now even the FDA Commissioner saying we need to get manufacturers to break the MMR vaccine into 3 components. And then they have pretty much set aside the MMRV vaccine. So tell us a little bit about the MMRV vaccine is and why breaking this could be potentially very problematic.
I think, first of all, just a global statement on breaking up vaccines. And Bonnie, I'm sure, has a lot of thoughts about this. But the whole idea is that it just makes it much more complicated for patients. And again, I'm not, one can look at all these individual decisions like MMRV and say, well, only about 15% of parents get that combination vaccine anyway. But what I'm worried about, and I think what many people are worried about, is this is just setting the stage for more fragmentation of other vaccines, like you said, separating measles, mumps, and rubella, having individual conversations about every specific vaccine, making it very burdensome in the healthcare system. And then at the end of the day, patients are confused, providers are confused. You have to discuss every single vaccine, and people are not going to get it. So again, with the MMRV on the surface, it doesn't seem like it's affecting a ton of people, but again, it's the precedent of what it's setting. And the idea about MMRV, and Bonnie can amplify, is that there was just a higher absolute percentage of people getting febrile seizures when they got MMRV versus people who got MMR. And I think on the surface, it seems scary to people, but again, it doesn't usually result in any untoward negative effect. And sure, you can break up and talk to people about it, but again, it's setting the stage for what's to come, which is to completely disentangle the childhood immunization schedule of all sorts. And it's, one can think about MRV, but it's about much more than that.
Yeah,
Absolutely. I think what you said, Peter, is absolutely spot on. And here's the issue, is that currently the CDC in general has never wanted to elevate one vaccine product over another. And that was the issue here. MMRV works just as well as MMR and V separately. There is a slightly higher risk of febrile seizures, but there are no long-term outcomes associated with those febrile seizures. We see them all the time in kids that haven't gotten vaccines. At least I have over my career. I mean, there are great studies demonstrating that febrile seizures in a healthy child don't have long-term outcomes. Now, there are some children who have underlying conditions, and the febrile seizure may just be a harbinger of what was an underlying neurologic condition. So it's not causing the underlying condition, it's just bringing it to light. And so what it does, as you said exactly, it provides less choice for families. and more than actually instead of more choice, which is what they're saying. And really, it makes the overall administration of vaccines. I mean, when when you go to your provider, you want to be able to be as efficient as possible. And taking away that efficiency really will make people be less likely to come in or want to discuss issues and wait longer times. I mean, the healthcare system is already pretty impacted post-COVID, and we're just going to see more delays. And that also delays our immunization coverage. And as you all know, measles has a really high R naught, a transmission rate of 12 to 18. So if we start losing vaccination coverage there, we're just going to see loss of our elimination status.
I mean, it's already happened in Canada, as people know, and we're on the cusp of losing that in the United States, Bonnie, like in January, right? I mean, there've been more than 1,800 cases of measles this year alone. And the point with losing the elimination status is that if the same strain is transmitted in a sustained way, so that same West Texas strain, even though it's lower in West Texas now, is going on in Arizona and other states. And I think that sustained transmission is what will make us lose that status.
Yeah. And so when we were
Canada has already lost their elimination
they
status.
lost it this year. So I was actually on the committee in 2000 along with Sam Katz and Alan Hinman were the chairs of that committee, and there were 22 of us. I actually went back to look at the report because those were such great days. We were able to meet several times and go over all the data for the US and the world, exactly as you said, Peter, looking at genotypic evidence as well as epidemiologic evidence. And we were very confident that we had eliminated. But one of the last things we said in our report, I went back to look at it, said this is a highly unstable situation. So elimination is highly unstable because it all depends on elimination status around the world, which we have not achieved, and on vaccination coverage. So we could eradicate measles easily, but we need people to believe and have trust in the vaccine system.
And we've talked about this in the past, but let's just quickly go over it because I think it's very important. People say, well, measles is no big deal. You just get natural infections with measles. Tell us give me 5 reasons why you don't want to get measles.
So number one, you can get really sick. I remember being, 4 years old and getting really sick. I still remember that memory. You can feel really awful. So that's one thing. Obviously, that's not such a big deal, but it's still something to avoid. Number two,
it's a big deal.
Yeah.
If you're a parent, you're going to miss work for how many days?
You're going to miss work. The kid's going to miss school. I mean, it is pretty significant. About 60% of kids who get measles have X-ray evidence of pneumonia, even though they may not be aware of it. So they're actually getting an organ, visceral disease. The other thing is about 1 in 1,000 of the kids can develop encephalitis. That is a big deal. And you can see long-term complications from encephalitis, 1 in 1,000. So that's a pretty reasonable number. About 1 in 3,000, 1 to 3 in 1,000 can die, especially if they're under 5. And what do they die of? They die of pneumonia. They die of normal diseases. And in addition, measles is an immunosuppressive virus. So if you get measles, you are essentially mildly immunosuppressed for 3 to 6 months after you're infected. It also destroys all your memory cells, your B memory cells. And so if you look at cohort studies from I think it's a Dutch study and other studies as well from Scandinavia, we have something called immune amnesia. So these are children who 5 years after they had measles now have a whole pool of depleted B cell. They have lack immunity to antigens to which they were vaccinated from those years when they got infected. So you do have a very big gap in your immune repertoire after me.
Bonnie? I think
Bonnie froze.
Yeah.
I'll just pick up until Bonnie comes up. I mean, I think so. Immune amnesia is one big reason. Another reason is the long COVID version of measles, which is SSPE, and which Bonnie had talked about before, where up to 10 to 15 years after the case of measles, you can get recrudescent disease. And I'd say one of the other reasons in the 5 or 6 reasons.
Measles disease. And then finally, there's a very encephalitis, and it's a chronic, it's a
Oops.
We
She's
lost her.
back. She's off.
Sorry
Oh,
about
Bonnie,
that.
you froze and you disconnected.
She's frozen again.
Yeah, so the last thing I would say, and then Bonnie will amplify, hopefully she'll come back on soon, is what you mentioned upfront, Carlos, which is the impact on caregivers. So every time a child is exposed who's not vaccinated to measles, to somebody in class who has measles, you're not talking about 5 days off. You're talking about 3 weeks off because that's the period of
Correct.
time for incubation of measles, which is different. And you can imagine a whole system and whole units of families and stuff being in a tailspin because of an outbreak in a school or a classroom, which will become more frequent as the immunization rate drops in the
But but
community.
but but if your child is immunized, you don't have to worry about it, right?
Yes.
So yes, something that creates an ability to continue to function as normal. So no, I mean between vaccination and getting measles, I'll take vaccination 100 times over. So
And,
Peter,
to the point of that Bonnie said about 1 to 3 per thousand dying, the fact that our numbers, we had 3 deaths, right, this year already. And the fact that our numbers, official numbers at 1,800 suggests that the actual
the actual number
count
is
is
much
much
different.
higher.
Yeah, I agree. I think there's way more cases than we actually hear about. So Peter, I got you now. Let's move on. Talk about uh, one of our favorite topics, which is respiratory viruses, COVID. Uh, where do you see things right now with COVID? Lots of changes in COVID vaccination. What are you telling patients? What are you telling family members? What are you doing yourself?
So I think, well, I got my COVID shot, even though I'm younger than 65. I'm a healthcare worker, and I don't want to be at risk. I mean, I just don't want to have it. But of course, I'm focusing talking to patients. I'm focusing on the lowest hanging fruits. You think about the shoulds and the coulds. The shoulds are definitely those who are older 65 and those who are very young, particularly under 2, and those who are immune compromised, including HIV patients, transplant patients. And then, those with comorbidities, although the age is probably the most important, one of the most important factors. In terms of type of vaccine, you can get any type. Again, there are 3 types again this season. They're all updated to LP1, which is kind of a GN1 variant, and um, Omicron, all Omicron, and very similar to last year. And there's a souped up version of Moderna, which has very similar outcomes. So it's essentially, a wash in terms of which vaccine you get. And in terms of what we're seeing now, kind of low COVID, but many people worry that we will see a later winter surge, mainly because the summer wasn't as bad, and but we don't know what will happen. Of course, it's unpredictable, but that we're always having background COVID anyway, so that's what's happening. In terms of Paxlovid, again, not as commonly used as before. But again, the person I would worry about with using antivirals would be somebody who should have gotten a shot in last year and didn't. So an older person, an immune compromised person, and they didn't get it recently. So that is probably the population I'd probably focus on more with Paxlovid. So that's kind of what we're seeing with COVID right now, kind of in the background, because everybody's RSV also is not as bad as people we have seen in the last few years. Right now, kind of lowish level, and this is the kind of time we would see RSV normally. And I think everybody's talking about flu this year. That's kind of the respiratory virus.
Well, let's talk about flu because flu, I think, is potentially going to give us a challenging winter, right?
Yes, it's going to give us a challenging winter for a few reasons. Um, One is that we made the decision, Bonnie, hi, welcome back. We went on to flu now, but we can come back to measles. I don't know if Carlos, you wanted to reprise
Yeah.
Bonnie, or we should just go along with flu.
Let's go on with flu and
So the reason why people are worried about flu is several. One is from the virus perspective, and one is vaccination status of the community. From a virus perspective, we made the decision about the components of the vaccine in February. But what happened with H3N2, which is an influenza A type, is sometime between June and August, it mutated, 7 new mutations. And that by itself doesn't mean too much. It's not like a shift, but it's kind of a drift. But what we've been seeing is the impact of that potential mutations on communities. Again, you never know if a mutation has legs until you see what it does to the community. And when you see what's happening in Asia, like in Japan, with 6 times more cases,
Australia.
Australia later, and then now in the UK, where they're having like crazy influenza, I think we're worried that people are going to get a lot more people are going to get infected more easily. People have talked about a mismatch potentially with the vaccine, but the UK did provide some efficacy data of their what they're calling subtype K, and it showed that it's up to 75% effective in kids at preventing hospitalization and up to 40% in adults. And you might think that sounds low, but it's kind of in the range of a what you could expect in some seasons with influenza. So that's the virus perspective. From the vaccine perspective, vaccination perspective, immunization rates continue to decline, most precipitously in kids. So, and Bonnie can speak more to this, but before the pandemic, kid vaccinations for flu were in the 60% range in the United States. It's like, in the 50s now, if not under 50 in some communities. And last year we had the worst pediatric flu season and just overall flu season in more than a decade, with almost 300 pediatric deaths, which is shocking but I think it's all driven by vaccination rates and kind of what's going on, apart from, other changes in flu types.
So Bonnie, we hear there's this K variant of H3, of influenza A. Is not a good match for the vaccine. So why should I get vaccinated?
Well, the vaccine still works. You will still be protected. You may not have the same degree of protection, but the illness will probably be mitigated as well. You probably won't be as sick. And that's what people are finding from around the world. We did note, as Peter mentioned, last year was a really big peak year since before the pandemic for influenza, but it was an H1N1 year. What's really unusual this year is, as you heard, is an H3N2. So we may start to see, H1N1 start waning again. And that's a real concern for what might happen in the future with maybe a big shift rather than just a drift. So I think we do need to message better. And this, I don't, nobody has really measured this, but I do think that we're seeing reduced vaccination rates overall, not astounding ones, but definitely lower vaccination rates across the board. And I think a lot of this misinformation and miscommunication make people wonder, as you said, is it worth it? Why should I do it? In the adults, influenza is a huge cause of tens of thousands of hospitalizations and deaths, and children as well. And we've seen a new entity called acute necrotizing encephalitis in children. We had over 50 cases last year that one of our neurologists here at Stanford was able to pull a network of people together around the country to study. We don't really understand what it is, but it's really a rapidly progressive neurologic form of influenza disease. Seems to be more common in children, but we really don't know that yet. So vaccination can actually help prevent a lot of the more severe complications, although not 100% effective for sure.
And I think that, again, is something we need to remind people over and over, right? The vaccines against all respiratory viruses, influenza, coronavirus, etc., are not necessarily very good at preventing infection, but they're very good at preventing severe disease, hospitalization, and death. And I think those are pretty good outcomes, quite frankly.
Well, and you bring up a great point, Carlos, and I think we talked about this a lot during the pandemic. I think we made a big mistake in talking about infection. We shouldn't be talking about infection. You can't get rid of infection. Other than measles, there aren't very many vaccines that provide sterilizing immunity. So most of the vaccines actually mitigate disease. They don't prevent disease, but they prevent complications and death. And that's really important. So I think, we don't want to raise expectations that people are never going to get sick, but they are going to be less ill and they're probably going to be less likely to go to the hospital, to go to the ICU, or to die. And those are the expectations we have right now.
Yeah, absolutely. I think this becomes something that we need to just say over and over, right? That the reason for vaccination
Yeah.
is a different one. So
Yeah, sorry I dropped off. Did you talk about the new H5N5
yeah,
No, not yet, not yet.
okay.
yeah, I wanted to go. Let's talk about that.
Yeah, so we were just getting an update yesterday from CDC, and as you all know, we've seen avian flu. It's been around. I mean, here in California, we've seen millions of birds being culled again. So this is apparently avian respiratory season as well. And so now that the wild flock are coming to our shores, we're starting to see this happen. And we know that in one county in particular in Northern California that has a lot of chicken farms, they produce a lot of the state's eggs. They had to cull millions and millions of birds and in some cases, they didn't even have to cull them. They just wound up with 20 or 30 million birds just dying of flu over a period of a week. And so, with that as a background, what we saw in Washington now was I think, third human case of H5 disease in the United States. That was the third death, I'm sorry. And this was a person with H5N5. And again, as you know, there's two proteins on the surface that confer virulence, and one is the H antigen, the other's N. And so you can have many combinations. Generally, we see a very limited repertoire in humans, but in birds, you can see up to several, almost a dozen H and N variants. And so the combinations are almost endless. And so this is a new variant. We don't know much about whether it's more virulent or less. And the person who passed away, we had chickens in his backyard. But he also had underlying immunologic conditions. So I think it is just a red flag to be concerned about watching what the next step is going to be at the federal level around managing avian flu. And I don't know, Peter, if you have any suggestions, because I really think we haven't had a great response other than tracking cases and culling birds, which is really kind of cart after the horse kind of situation.
I think one of the potential interventions comes from our animal colleagues, which is vaccination of cows and birds, but they've been really reluctant to do that from a business perspective. Because what happens when you vaccinate an animal is that you turn positive on an antibody test, so it makes the products less competitive on a global perspective from a Department of Agriculture thing. So they've been kind of coy about trying to do that, although like in Hawaii, they're vaccinating seals and all sorts of things because of this pandemic that's happening in birds that Bonnie talked about. So that's one thing. The second thing is that we all talk to our regular patients about really trying to get the flu shot, regular human flu shot, just to prevent what you talked about, Bonnie, of as these birds fly over coming to roost in the south for winter, they affect all these zoo animals and all these backyard birds, and they can reassort with human. If there's a lot, the lower the chances of them coming in contact with a human strain of flu, the better it is for lowering the chances of exchanging genes to make it easier to enter human bodies. So regular vaccination, of course, California and others had last season had these programs to vaccinate migrant farm workers, and I hope they continue to do that this year. The third is, of course, raw milk and cheese, which is something that we saw we was such a big debate. But that's the thing at least in California where people are usually very liberal thinking, but liberal also means that usually want to have farm to table and have everything pure and natural. So there was a little clash of people who wanted their raw milk and cheese potentially. But again, the higher risk of all of these birds and cows being infected, the higher the chance of you getting infected with highly pathogenic avian influenza from one of these products. And then, of course, not the usual things, not handling dead animals and birds, worried about your cats. Those are some of the things. And I would say, yeah, so those are some of the things that I talk about with
Yeah.
patients.
Yeah. The other thing to remember, I think, is that fortunately, we have not seen in the US anyway any human-to-human cases of human-to-human transmission cases of avian flu. So that, and of course, would be the ultimate fear, right? That not only would this spread to humans from animal vectors, but then there would be human-to-human transmission, which we haven't seen in the US, and very few cases outside the US as well. So but you know, again, that's a bit of a ticking time bomb.
So Peter, let's move on and talk a little bit about of long COVID. Anything new on long COVID?
Um, Nothing new except that, research continues to be at risk of, I mean, a lot of people I know have had funding pause, et cetera, around some of these studies, and Bonnie might have more information about it, and you too, Carlos. So, I haven't really seen anything new, but maybe both of you have
Yeah,
some.
well, we're continuing to do the recover trials here at Stanford in adults, and we're trying to set up some studies in children. We just don't have a lot of kids, at least here at Stanford, but there are pediatric and adult recover studies, and they continue to publish their data. I think, for POTS and others, some of these other well-known syndromes, people are starting to, of course, they're still doing their clinical trials, but we really haven't seen anything really pop out as new. And fortunately, those trials are going on, and we're seeing at the NIH level, they're still monitoring some of these other trials across the country. I think Recover just had their national meeting last month, and I think really just trying to continue to follow patients. It's a slow process at this point because it's such a multifactorial and a multi-dimensional syndrome, which again doesn't have one set of criteria.
Yeah.
And unfortunately, like you said, Bonnie, nothing has been shown, at least Paxlovid, into studies of
Yeah.
5-day courses. And the 15-day course one, I haven't really seen any results
Yeah.
from that yet. But then just yesterday, a pediatrician actually texted me to ask me, she had a 8-year-old kid who had long COVID symptoms and had ADHD, was getting worse with the symptoms, and wanted to know if she could use Paxlovid. And I said, no, really, for two reasons. One is that even in the adult trials, it hadn't really shown benefit. And then number two, to use it off label for a kid under 12 for that reason, I'd be a little bit more nervous about. So, that's kind of where we are.
Yeah, nothing new yet. I don't even know if people are taking Paxlovid anymore.
Yeah.
Yeah, I know. I think it's
Yeah.
I'm reserving Paxlovid for
Yeah.
very few people, high risk
Yeah.
individuals,
I
over the age
agree.
of 65, 70 with COVID, that I think the risk of complications is high, but other than that,
Yeah.
I'm not using it.
So, Carlos, one paper that just came out, and we've been waiting for this paper to come out, but it was in the New England Journal this week, and it was the 1-dose versus 2-dose HPV vaccine trial.
Yes.
And this is again one of the reasons why we're also worried about ACIP is that we're so busy revisiting old established science. We're not moving forward. We were supposed to discuss the possibility of using a 1-dose HPV vaccine schedule rather than 2 doses. And the data that came out from this Costa Rican study called Escudo in New England Journal, sponsored by NIH, demonstrated that in over 20,000 people, when you compared 1 versus 2 doses, the 1 dose was non-inferior for outcomes of not only immunogenicity, but
And we've known that from many places around the world are down to one
they're
dose,
already
right?
doing it. Yep. Yep.
Yeah.
I mean, I think it was helpful for us to wait for our studies rather than to rush into it. But I do think that, again, if anything, it makes the vaccine, you're exposing people to less doses, and it's really, looking at the reduction of. So if you look at the national scene, and we saw this even in just some preliminary work that I did in my lab, in my research team, we're seeing reduced numbers of cervical cancer rates, primary CIN disease in women, and haven't been able to look at males because the risk is so low the numbers are much lower, but in women, we're just definitely seeing in the age group that has been vaccinated, we're seeing major reductions in HPV related disease. And
Oh,
that
we're
is,
we're seeing in many countries almost an elimination of
yeah,
cervical carcinoma
yeah,
because of this vaccine.
yeah.
Well, Bonnie, there's a lot of papers that have dropped and new papers, new science that keeps appearing. And I'm going to call on you because there's a paper in pediatrics in which you are one of the authors. The paper, I'm going to put it in the chat for people to, if you want to put it in the, I don't know, the chat of the Q&A. I don't know where to put it, but the reference, the title is The Role and Safety of Aluminum Adjuvants in Childhood Vaccines. We've heard a lot about alum lately. And so tell me a little bit about that and tell me, most importantly, why is this so critical? And thanks again for writing this paper. I think is really important.
Yeah, well, I have to thank my colleagues at Stanford and my other, so this is Seth Hoffman, and then one of our colleagues from your local epidemiologist who actually really did all the heavy work. We reviewed over 800 papers around aluminum salts adjuvants in vaccines. And why did we do it? Well, we've been using them for literally 100 years. And the data have been very striking, but there have been, again, this whole anti-vax trope that aluminum salt adjuvants are causing neurodevelopmental disease, are causing all kinds of autoimmune disorders. They may be involved with autism. There's all of this pseudoscience, no data to demonstrate that this is true. This is going to come up. Actually, they may be talking about it right now on the ACIP meeting. They were supposed to talk about it today, but they may have run out of time. But if they don't bring it up now, they'll bring it up at the next meeting. And so we really thought it was important to go back and review, not only pull up the old papers, but write a new paper with a new review. We actually pulled up 800 papers. And of those papers, we focused in on about 400 or so that really looked at the state of the art around aluminum. Aluminum is the third most common element on the planet. We get aluminum from everything we do, from what we eat, what we drink, what we wear. It's everywhere. And it can be toxic in very high levels if ingested or ingested in a variety of forms in very high doses. But the levels that are given in the entire pediatric and adult immunization schedule are minute. They're very, very small. They're 10x orders of magnitude or more less than any toxic level that could be given in humans or even in animals to cause any kind of side effects. And they are really necessary to boost, especially for subunit vaccines, because subunit vaccines and protein-based vaccines may not have sufficient stimulation of the immune system to really get a good response, and adjuvants do a very good job there. So they really are helpful in boosting the immunogenicity of vaccines. They are incredibly safe. There have been, again, 100 years of data looking at safety, and no safety signals have really been found with adjuvants. And yet we are facing probably in the next, few months, some real resistance. And actually, we've heard independently, not officially, that that the administration, the HHS, is thinking about is studying whether to remove aluminum salt adjuvants from vaccines, which would mean that virtually half of our vaccines available for children and adults might actually have to be taken off the market and restudied with who knows what other adjuvant. I don't know what adjuvant might be considered safer than aluminum because it's incredibly safe already. So we wrote this paper in an attempt to educate our scientific community about this, because it's something that, to be honest, I hadn't really thought about it much in the last, 40 years or but it's time to rethink about it and bring it back up so that people can see the data is there. There are data there, and they demonstrate safety and immunogenicity.
Yeah, it's so clear. It's so to me, it's just so concerning that we are attacking the wrong thing, right? And we're spending time. I say over and over, and this is when I think about the number of kids that die from gun violence, the number of kids that die from other reasons, the number of kids that die of lack of food and not having a home, those are the things we need to be worrying about as a society, and those are the things that we need to care about if we really truly care about childhood health and providing a safety and effect and secure childhood to our children.
Yeah.
Um,
Well, by the way, there is another paper that's not infectious disease related specifically, but it's written by James Perrin from Boston Children's Hospital and Tina Chang, who's in Cincinnati, and she's the chair of pediatrics there. They wrote an op-ed in the New England Journal last month around MAHA, and they said, look, the idea of MAHA, or Make America Healthy Again, in specifically around kids, great idea, but here's where you miss the mark. Here are the things that you should be addressing: ultra processed foods, things that you talked about, gun violence, social disparities of health, health disparities. And they do a very nice cogent database job. So if people want to look, don't have time to look up the link now, but maybe we can get the link for people to look at. It's a early November New England Journal op-ed, and it's Perrin, Perrin, and Cheng, Cheng, the two authors. And it really does get an overview of the MAHA Commission report and what we should be doing to really, really try to make health better in this country. What are the things we should be focusing on?
yeah, we need to prioritize childhood health. There's no doubt about that, right?
Oh, there,
And
great. There's a link.
yeah, and we have to really, but we have to do it addressing the right issues.
Yeah. By the way, speaking of new issues, I was listening to Eric Topol. He came to Stanford this week to talk about his aging book. I forget what the Super Agers. And one of the things he talked about that was really interesting is, and Eric is a, polymath, right? So just like you, Carlos. And so he talked about the fact that varicella zoster vaccine and the whole role in preventing dementia. It's a really interesting idea. And one that, that obviously we should study more, but it's something that you can already do because the vaccine is already approved. But it appears that people who get the vaccine have a much lower risk of going forward to have develop dementia. Now, I'm not saying it's the cure or the treatment for dementia, but certainly there have been associations with varicella zoster vaccine. And so it's not related probably to anything about the virus, but more about immune activation
And
in the brain.
activation, inflammation, all those things that we all talk
Yep.
about and that we all care and love, right?
Yep.
Yeah. So we have a couple questions. And a question, somebody, a Cameroonian virologist who is at the University of Rome, has two questions. What are the most critical global gaps in early detection of emerging infections, and what concrete actions are needed to strengthen preparedness across low, middle, and high-income countries?
Yeah. I mean, I'll let Peter talk about this too, but I think this has been an area that we come up with a pandemic preparedness playbook, it seems every 4 years, and then we don't use it, or we don't fully staff it. Now, we already know that we have a polio and a flu network around the world. We have over 147 laboratories in over 70 countries right now that track flu and polio because we're eradicating polio and because we want to track flu as well. Those are at least at a bare minimum opportunities for us to do surveillance for other diseases. It's just a matter of putting those together. A wastewater surveillance is another very easy thing, not just to look at infections, but also antimicrobial resistance or even other types of diseases, tracking drug use, for example. So we absolutely have the technology already. What we lack is the political and the public health will to be able to do this at a global level or even at a national level. So I don't think there's any question about what needs to be done. Surveillance is important, and then trying to build genomic profiles for risk. What are risk factors for virulence in different viral classes? I think the big pathogens that we worry about, number one is avian flu, of course, but the other ones that we don't really talk about much and are really a big deal are flaviviruses. And if we could look now, people are looking at group flavivirus antigen approaches because they're all, if you try to develop a vaccine against Marburg or Ebola or one of the others, and there, by the way, there is a new prototype Marburg that was just shipped to Ethiopia because they have an outbreak now. So there is a prototype vaccine that's going to be tried there. But the point is, if we can actually build out that portfolio of flavivirus vaccines as well, because those are also pretty reasonably highly transmissible, not as high as measles, but still reasonably transmissible. And they have a very high fatality rate, and there's really no treatment for them. So I think building out our vaccine portfolio, understanding virulence factors, and trying to take a broader approach to surveillance that includes, really some kind of good global approach to surveillance and tracking. I don't know, Peter, what do you think?
I mean, I agree with you, Bonnie, but what I always have learned from you is the other piece of the developing the technology part, which is implementation. And what we learned during COVID is that you can develop the fanciest technology and have the best minds of Silicon Valley work on the best antigen tests. But if you can't get it to people in the communities that they need, you might as well have done nothing, because of all the global aspect of of infectious disease. And that is, we're in a troublesome time of being very insular and not sharing and pulling out of WHO. And so I worry about the implementation part, and then the narrative around some promising technologies that are at risk, like mRNA vaccines, where in a fast-moving pandemic, you cut and paste and can develop that vaccine in 2 months or so instead of
So,
many months. So those
so,
are
so,
some of the threats.
so next question quickly. We have only a few minutes left. Uh, Jeff Kishner asked a question. I heard of a COVID deaths in our community this past week, but then realized we haven't heard little or nothing about cases. What makes selling this to patients a bit harder? Are you aware of any state or public health departments tracking COVID cases any longer?
So I know I think our county is tracking cases, and I think the state of California is still tracking cases. We're actually using a lot of wastewater data
Wastewater
too.
surveillance is really what I think a lot of us are
Yeah,
doing, right?
yeah, we're doing. I mean, because and that's the whole point of wastewater, right? The low prevalence disease in the hospital, for example, we're seeing very few cases right now. So I think, and I don't know what I imagine you're seeing the same at UCSF. So I think that the issue is if you are a high risk patient, and we know what those are. I mean, I still think people should consider getting vaccinated because you don't know when you might see a surge, and even if you don't see a surge, you might be that person. It's like pneumococcal disease. It's not that highly prevalent, but if you don't get vaccinated and you're in risk, you're going to get sick, and it can go very quickly.
Yeah, I
The other,
mean, it was striking to me that the number of deaths of COVID in 2024, when it's supposed to be not a big deal, was 48,000.
yeah,
So that's shocking to me
yeah,
because we never had those people would not have died before 2019.
So,
yeah.
so I'll give you some numbers here from Emory Healthcare in our hospitals the last 4 weeks. Influenza A and B, is primarily influenza A, has gone from 1.7% at the beginning of November to 7.6% of people we test are testing positive. So almost 8% are testing positive. COVID is pretty flat, about 1.9, and actually coming down this past week, only 1%. And RSV has gone from 1.5 to about 3%. So again, we're seeing a huge uptake on influenza A, kind of flat to going down on COVID, and RSV starting to go up. So,
Yeah,
you have to know your local epidemiology. You have to know what's
right.
happening at your local level, and you really need to do whatever you can to really get your hospital data, your county data, your
Yep.
safe water, your wastewater data, and go from there. So 1 minute
So
each.
one last thing, Carlos, I think we have to mention it. It's December. We did not celebrate World AIDS Day this
Yeah, I
year.
know
That is
that
a
was such a
tragedy. That
yeah.
is a tragedy. And that is a disease that we can eradicate by 2030 without a vaccine. We can, but we won't. I suspect. And that
Yeah,
is a
you
real
know,
concern.
not having World AIDS Day really felt personal. I've lived through the entire epidemic, and it really felt like somebody in my family had passed away. It's really sad to say that, it almost feels like the you know we're pulling the our best pitcher in the seventh inning. I mean, we're
Yeah.
we're we're closing in on this game, and all of a sudden we're giving up. And
Well, just so you know, I started the pediatric HIV clinic here at Stanford. All of my patients, all of them died.
yeah,
So I didn't have the same success that you've had as adults. And now we don't have any more pediatric cases. So but we're still seeing cases in other parts of the world.
but I would say again,
This isn't over.
the government didn't commemorate, but I agree with Dr. Kishner. We did a lot of events locally, and a lot of things were happened to commemorate World AIDS Day. I think, there was not a national position, but the government didn't say anything, but the federal government, but a lot of things happen locally. And again, local communities need to be stronger than ever.
Yes.
And local communities need to work to keep public health, because public health happens at the community level, public health happens at the local level. And more than ever, we need to work as communities to strengthen public health and to help the health of our communities. So I want to thank both of you. This was very entertaining and very informative. And I look forward to talking to you the next time around. In the meantime, enjoy the holidays.
Yeah. Happy holidays, everybody.
Happy holidays.
I want to thank IAS-USA. You could go to the website. There's a lot of information there. Coming in February, you have CROI, the Conference on Retrovirus and Opportunistic Infections. Also, the Ryan White Conference is coming up. And again, I recommend the Going Antiviral, the podcast conducted by my friend and colleague, Dr. Michael Sag. And there's always good information there. This past week, he interviewed Rochelle Walensky, and it's a terrific podcast. I strongly encourage you to hear it. And again, in February, we would have a webinar on changes in guidelines, new publications, recent conferences with Dr. Connie Benson and Roger Bedimo discussing. So thank you very much, and look forward to seeing you soon.